You may increase the overall gain to the entire screen by turning the gain dial clockwise. Likewise, you may turn the gain down by turning the gain dial counterclockwise. There's also an easy button that automatically adjusts gain. When you press this, it pauses for a split second, then chooses the best gain setting. Next, you may use the slider to preferentially adjust the gain at different levels of the screen. The near gain sliders affect the near gain, while the far gain sliders affect depth is an important consideration for any scan. You adjust this by pressing on the depth button on the console. Pressing up on the depth button decreases the depth, making the image more shallow. Pressing down on the depth button increases the depth, making the image deeper. The goal is to avoid having unused imaging space in the far field, so use your depth on every.
Hi everyone, it's Rob Arnfield speaking to you from Western University again. I'm going to talk to you today about lung and pleural ultrasound. We've previously spoken to you about lung acquisition techniques and our protocol or sequence we use here at Western. If you haven't seen that, I would suggest watching that first. The biggest rub with lung ultrasound for most people is the fact that it's non-anatomic. When you look at the rest of point-of-care ultrasound, you look at the anatomic images like this FAST exam with fluid around the kidney, the liver. You can show that to patients' families, to the janitors, to the nurses, to the hospital CEO, and everyone understands intuitively what they're looking at or can get behind it a little bit. But when you show somebody this and try and tell them that it represents pulmonary edema or ARDS, it's a bit more of a leap of faith because it's artifact driven. As you increase your proficiency and your use of lung ultrasound, however, these artifacts become a new language, and your fluency in interpreting them and acting on them becomes greatly simplified. So today we're going to emphasize the 5 ultrasound signatures that you can see in the thorax when you put a probe on a patient who has acute respiratory failure. Any given patient will have any number of these different signatures present in their chest, and integrating these into one representative respiratory diagnosis can sometimes pose a challenge, or is certainly something that you will get better at over time. But at first, the most basic level is you must recognize the signature of the artifacts that you're demonstrating. So let's start with sliding lung. Sliding lung is the most classic of lung ultrasound artifacts and is the one that everybody should know. Its value in particular relates to excluding pneumothorax, which it does with 100% certainty at the site of your transducer. So with a couple quick points on the chest, you can take a life-altering and life-threatening pneumothorax off the table in a matter of seconds. To understand lung sliding, let's take you through a couple schematics. First, the sagittal projection across the ribs is going to show you this type of picture. And in this screencast, we're going to show you a lot of vascular or linear array images just because they're more vivid, are better for teaching purposes. But in practicality, as I spoke in the last screencast, we tend to use a phased array probe most often. So here's a typical image of lung sliding with the chest wall, rib shadows on either side of the ultrasound screen, a bright hyperechoic line, which shows some degree of dynamic movement or shimmering or sliding, call it what you like, but there's movement there, which tells you that the lung is up. And deep to the pleural line is really a sense of nothingness that's cast by the air, as air doesn't provide any meaningful information to ultrasound, as it causes immense scatter to the ultrasound beams. So this is a classic picture of a lung sliding image. Now let's move on to parenchymal findings, because lung sliding largely relates to the presence or absence of pneumothorax, but we also want to know whether or not the lung is diseased or not. And so we're going to be talking about 2 signs in succession now, one called A lines and one called B lines. Now A lines are cast in the setting of ultrasound and air, and if the ultrasound is exposed to air and the air itself is not interrupted by things like fluid or pus or hemorrhage or lung injury, then it produces something called A lines. And so the effect is, if you see an A line pattern in lung ultrasound, it suggests that the parenchyma itself is not diseased. And so if you can demonstrate an A line pattern throughout a chest, you can effectively rule out parenchymal disease as the cause of respiratory failure, and therefore consider differential diagnosis that includes non-parenchymal disease, such as airways disease like COPD or asthma, pulmonary embolism, fatigue from metabolic acidosis, you name it, but it's unlikely to be things like CHF, ARDS, pneumonia, pleural effusion, other things that are causing parenchymal disease. So let's look at the A lines themselves. Here we have a image captured with a phased array transducer. You can appreciate the pleural line up here with more of a kind of a shimmering appearance to it than sliding, which you'll find it'll take on varying appearances in different patients. And then you can appreciate that there's a horizontal kind of repetitious line that is equidistant beneath the pleural lines, the same distance as the distance from the pleural line to the surface of the transducer. And so these lines are superimposed upon one another, and this is just a normal artifact that you see in the setting of aerated lung that is unimpeded by other disease process. So A lines are good. And now, because I've told you A lines mean that the lung is unhindered by fluid, for instance, it's been shown that an A line pattern, if you see A lines throughout the lung, correlates quite well with low left atrial pressure and can effectively rule out elevated filling pressures on the left side, which in the context of large volume resuscitation, in addition to a cardiac assessment, can give a lot of strength to a management strategy that would involve more fluids. So the sibling lung signature to the A line is, of course, the B line, and the B line, a vertical hyperechoic finding that extends from the pleural line itself. It moves with the pleural line, and it must extend to the bottom of the ultrasound screen. And this artifact, as we'll review in a moment, is created by fluid or thickening in their interlobular septae between the alveoli. And often this occurs before fluid accumulates in the alveolus, and often before X-ray findings even can demonstrate edema. So it's an incredibly sensitive finding for fluid or fibrosis or thickening in the alveolar interstitium. So let's have a look at some B lines here, again acquired with a phased probe. You can see a rib shadow here and a rib shadow here, but the bright pleural line you see is casting these light rays or lung rockets or B lines, call them what you like, but you can see they move with the pleural line and they must go to the bottom of the ultrasound screen. So even if we increase the depth, you'd still see the B lines shooting down all the way to the bottom of the screens. What do you make of B lines? Well, generalized B line pattern suggests the same thing as an interstitial syndrome on CAT scan, or what they often call a ground glass architecture on CAT scan. And the differential is similar to what you would make of for an X-ray that looks like this if you had diffuse B lines, so things like CHF or ARDS. If you had unilateral B lines, you might consider things like pneumonia in its early phases, or again, a bilateral picture with interstitial lung disease as well. Most commonly, we're interested in the CHF or lung injury patterns for B lines for rapid diagnosis of an alveolar cause of respiratory failure. So there's obviously a spectrum of the burden of B lines you can find in any ultrasound window. And a single B line we all harbor every once in a while. We all kind of accumulate a bit of fluid. But as soon as you exceed 2 and you get into 3 or more B lines in an ultrasound field of view, then you start thinking it's pathological. And so here we see kind of a pathological number, and here we see very almost coalescing B lines in this rain shower kind of appearance on the lungs, which is much more severe. So finally, we move to some lung signatures where you actually get to see the lungs, and the good news is there's some anatomic signatures with the lungs that aren't just artifact based. So you can see lungs when they lose their air in the context of consolidation, or when they're surrounded by fluid in the context of an effusion. So here's an example of lung sign number 4, what we call a consolidation pattern. Here we have a pleural view on the left side with diaphragm, spleen. We have a solid organ density above the diaphragm here, which represents a completely collapsed left lung. Now, the etiology of consolidation is the de-aeration of that lung, whether it's complete atelectasis or if it's pneumonia that has replaced the air with fluid and pus, is a matter of clinical correlation. And there are some ultrasound signs that many will speak of that can help you distinguish between them, including dynamic air bronchograms. We're not going to get into that today. Really, just the bottom line is if you see unilateral consolidation, somebody with a fever and a white count, I'd favor pneumonia. If it's bibasilar consolidation in a patient who's been ventilated for a few days and is otherwise afebrile, I'd favor atelectasis. So you do have to correlate it clinically, but often very helpful finding in patients with otherwise undifferentiated respiratory failure, because even a degree of this much of consolidation is often occult to chest X-ray, you'll find. And the last sign, a very common sign that's very familiar to many practitioners of all specialties, is the pleural effusion sign. And again, a left upper quadrant or left pleural space view, diaphragm, spleen, black is fluid, and the lung itself is collapsed under the burden of the fluid. Now, it's important to recognize that collapsed lung under a burden of fluid is not consolidation. It's an appropriate amount of consolidation, but the primary process in this case is a pleural effusion itself, and the lung just can't get air into it under the burden of the pleural fluid. So here's another example. Again, nice picture here of spleen, diaphragm, and collapsed atelectatic lung, appropriately though, because you can see how it's encased in fluid. And to diagnose pleural effusion, you really need to see the chest wall. You need to know that you have a diaphragm. Really, you must identify the diaphragm. Not everything that's black and near the chest is an effusion. And you have to see dynamic signs. You have to see the diaphragm move or the lungs start flapping to really be sure that that's an effusion, in particular when you're looking to stick needles in it.